And Dr. Aita Mustafa Bhai says, my topic is assessment system for control of asthma and severity of COPD. I like to clear that in regard of asthma, the term is used control, and for the COPD, the term is severity. So, for this reason, I want to clear that in asthma, the eosinophil is the center of inflammatory cells. So, if you see the molecular level, the eosinophil is effective by the systemic steroids. So, this disease can be controlled. And the second cell, the mast cell, which is the primary cell of the asthma, this is in recent concept, asthma is a mast cell myositis, and the mast cell is also synthesized by the corticosteroid. So, by the use of corticosteroid, asthma can be controlled, but in COPD, the central cell take place role the neutrophil, which is not sensitive by the responsive by the steroid. So it cannot be controlled. So the progression from neutrophil proteases either to mucus hypersecretion causing chronic bronchitis or alveolar cell destruction causing emphysema. These two conditions cannot be controlled. Only we can reduce the progression of severity from one stage to another. So, for assessment of our treatment, we can assess the asthma for control and for the COPD only the severity. And there are various tools for assessment of control of asthma as well as the severity of COPD. And now, what is the control of asthma? Control of asthma means control of the clinical manifestations or degree to which the manifestations of asthma are minimized by the therapeutic interventions. And this is the goal of asthma management. And increasingly this concept is accepted throughout the world. The control of asthma is classified totally controlled, partially controlled, uncontrolled. And complete control is achieved only by the treatment. And we need, already the last speaker already told that, we also need to achieve and maintain this control for prolonged time. We give to attention to the safety of treatment and cost of treatment also. And as asthma is reversible disease and it is responsive by steroid, so we can control from disease to the normality. And for monitor of control, we need to see the several points, so like adherence, and also we have to make a realistic goal. And we need to adjust the treatment by a step up or a step down, or sometimes we refer to the other centers. And what is meant by the total control? Total control means no daytime symptom, no nighttime symptom, no use of relevant medications, if need, no more than 4 or more times, no school or work abstinence, and normal breathing test, as well as no exacerbation. And for assessing the control, self-monitoring technique is the best way, either by symptom or peak flow monitoring. And peak flow monitoring only discussed by the previous presenter, how can we monitor the peak flow. And the Royal College of Physicians 3-question test, we can also assess the asthma control by asking the 3 questions only. That is, have difficulty sleeping, or asthma symptom during the day, or interferes with usual activities. If all 3 is negative, then the asthma is totally controlled by this method. And if there is any yes to any question, it is not controlled. And this is not well validated. But for quick assessment, it is a very good tool. And now the asthma control test, which is the recent advancement, is still not validated, already discussed with the last speaker. It is a 5-point procedure. This item is scored from 1 to 5. 1 is poor control, 5 is good control. And total score is 25. First, we write the number of this answer in the score box and then add the score and then interpretation. And this is the first question. It relates to the previous past weeks only. We can assess only the last 4 weeks assessment of control. How much the time did you asthma keep you from getting as much done at work, school, at home? All of the time, most of the time, some of the time, a little of the time, and none of the time. And the 5 questions during the past 4 weeks, how often you had a shortness of breath, something like this, and then the symptom of wheezing, shortness of breath, cystitis, and the last 4 weeks, how often you have used your reliever medications, and also your asthma, that is the expression of the patient. What is his expression? It is totally controlled, poorly controlled, somewhat controlled, well controlled, completely controlled. And after asking the 5 questions, the total will be 25. If the score is 25, not more than 25, then it is total control. And then the treatment will be, action will be either maintain the treatment or step down. If the score is 20-24, then it is well controlled and maintain the treatment. But if it is less than 20, that is 19 to 20, not doing well, so step up, and less than 9, and it is chance of exacerbation. And another also asthma control test for the children. And now the assessment of severity of COPD, there is so many assessment systems. FEV1, there is a grading system for FEV1 and various systems, and the MRC scoring system. There is also a grading 1 to 5, and then the comprehensive testing system by body index, board index, and the board index is shown by this one, and now the COPD assessment tool or test, which is the latest achievement, and it is a validated complete questionnaire. Multidisciplinary group is invented this one, and it has a 0 to 20 scores, and as like asthma control test ACT, they can also the same 8 questions here, and 0 to 5 point will be getting, and a total of 30 point can be getting. If it is more than 30, it is very worse. Just reverse the asthma control test. So the patient has no good day on the day, but still there is a room for improvement, and there is a chance of treatment. So there is so many things can be taken. The patient can be referred to the specialist care if the involving physician is a primary care physician. And also additional pharmacological treatment can be given, or pulmonary rehabilitation can be introduced, or various treatment or medication can be given. If it is more than 20, the impact level is very high. Also, the patient has some good or bad day, but equally he has some bad day also, and the result is taken just like same as if it is very high. And if the score is 10 to 20, it is a medium level of impact, and they have a very good week, and treatment need to optimize the treatment again. But if it is less than 10, the impact level is very low. The most days are good, the patient is very well, and then only the smoking cessation, annual immunization, and exacerbation prevention is the main goal. So, thank you very much for patient hearing.
Thank you, Dr. Ruposi, for your elaborate presentation. Now I request Dr. Sohaib Rezaul to present his topic, pneumococcal infection of asthma and COPD patients, impact for control, a global perspective.
Respected chairpersons, knowledge audience. Today I am going to talk topic pneumococcal disease, global concern, impact on COPD and asthma. Globally, pneumococcal disease is a leading cause of death in young children and older adults, which is represented in the graph. Invasive pneumococcal disease preferentially affects the young and older adults. Here there is another curve which is showing incidence of invasive pneumococcal disease creates a U-shaped curve with peaks at extremes of age. That is under 6 to 11 months and over 65 years of age. Major clinical syndromes of pneumococcal disease, US data which shows the pneumonia is over 500,000, bacteremia only 50,000 and meningitis is 3,000 estimated annual cases. All-cause non-invasive pneumonia classification. Here we see community-acquired pneumonia, hospital-acquired pneumonia, ventilator-assisted pneumonia, healthcare-assisted. Community-acquired pneumonia in the non-hospital or healthcare facility setting. The hospital-acquired pneumonia and ventilator-assisted pneumonia in the hospital wards and intensive care units. Healthcare-assisted pneumonia where prior hospitalization during dialysis, during nursing, home residence, and immunocompromised patients. Lower respiratory infections, a leading cause of disease globally. All ages, 2004 data shows LRPI is the number one. Which is also a pneumococcal disease. Global burden of community-acquired pneumonia in USA data which shows annual cases of 5.6 million, where annual hospitalization is 1.3 million, and annual death is more than 55,000. In European countries like Italy and Spain, the annual incidence in Italy is 1.7%, hospitalization rate is 31.8%, mortality 6%. But unfortunately in Bangladesh we have no such data. Age and comorbidities are risk factors for community-acquired pneumonia. Here we see age more than 65 years, regular cigarette smoking, chronic bronchitis, heart disease, hypertension, diabetes mellitus, alcohol consumption, immunosuppression, asthma, chronic liver disease, and malignancies. Incidence of community-acquired pneumonia due to all causes is highest in older adults. You see in New Zealand data, age more than 85 has got the highest. Also in England, more than 75, age more than 75 to 84, also more than 85 is the highest. Same is the situation in Italy and Spain. And the proportion of older adults in the global population is increasing, which is evident in the curve. You see pneumonia will be increased more than age more than 65 year 2040 and 2050. Now the microbiology of community-acquired bacterial pneumonia in adults, where a meta-analysis shows Streptococcus pneumoniae is the first culprit agent, which shows 4,432 patients, and the mortality was 12.3, which is followed by Haemophilus influenzae, then Mycoplasma pneumoniae, then Staphylococcus aureus, then Klebsiella species, then Pneumococcus aeruginosa, and lastly followed by Escherichia coli. And WHO data showing global mortality of pneumonia in 2005. In South Africa, male was 89.7, female 97.4, Argentina 38.38, and female 39.7. In 2006 data in Japan, it is showing 91.9, female 78.5. Germany 22.6, female 26.6, and Korea at 9.7, female 9.1. And the proportion of adult patients in US reporting symptoms during resolution of all cause of pneumonia in 1997 data, where shows fatigue was in day 0 93%, day 7 80%, day 30 65%, and day 90 51%. Followed by cough 90% in day 0, and day 90 32%. Dyspnea day 0 68%, day 90 28%. Sputum day 0 63%, day 90 27%, and fluotic chest pain day 0 47%, day 90 8%. The antibiotic resistance among Streptococcus pneumoniae isolates where in 2004-2005 data shows erythromycin in Europe 24.6% and US 21.9% resistance, tetracycline 19.8% resistance in Europe, US 15.8%, ceftriaxone in Europe there was no resistance but in US 5.8%, chlorpheniramine in Europe no resistance but in US 4.9%, ciprofloxacin in Europe 2%, US 1.1%. Now, what is the impact of pneumococcal disease in COPD and asthma? You know, COPD and bronchial asthma are the two most common diseases showing frequent exacerbations when treatment is not proper and patient compliance is not poor. And a lot of factors are involved in this exacerbation, of which the infection is the most common one. Among the avoidable situations, by far the most common and important one is infection, either bacterial or viral. And among the bacteria, Streptococcus pneumoniae is the commonest pathogen in both cases, which is also a commonest organism in chest infection, especially in different immunocompromised patients. Bacterial infection is affected in 70 to 55% in the exacerbations, with up to 60% caused by pneumonia, followed by nucleus influenzae and Watson pneumonia. The presence of an upper respiratory tract infection leads to more severe exacerbation and longer symptom recovery time and exacerbations. Now, proposed hypothesis is about the relation between asthma and increased risk of pneumococcal infections. Asthma patients have disrupted airway epithelial barrier, increased abnormal mucus production, increased risk of pneumococcal nasal colonization. Asthma medication may be immunosuppression. Patients with asthma have at least double the risk of invasive pneumococcal disease compared to persons without asthma. Even without coexisting high-risk condition, asthmatics are increased risk for IPD. Now, WHO recommendation for vaccination. Various studies have shown polyvalent pneumococcal polysaccharide vaccine provides 65% efficacy in preventing pneumococcal infection in COPD. Simultaneous influenza and pneumococcal vaccination provide additional benefit among elderly persons with COPD, and health companies data support the cost effectiveness of pneumococcal vaccines. Now, in summary, I would say pneumococcal disease imposes a significant burden of disease. Worldwide distribution, high mortality rates in children and older adults, includes all invasive forms and non-invasive forms of pneumococcal disease. Significant impact on global mortality and mortality. And Streptococcus pneumoniae is the most prevalent bacterial pathogens. Age more than 65 and numerous other comorbidities such as heart disease, COPD, smoking, asthma, and diabetes increase the risk of care. The incidence of gap is uniformly higher in patients more than 65 years compared with young adults. The exacerbation of COPD and asthma can be prevented by vaccination against pneumococcal disease. There is a global concern over increasing antibiotic resistance in Streptococcus pneumoniae isolates, and surveillance programs are needed to monitor prevalence and trends of Streptococcus pneumoniae. Thank you. Thank you all.